Hello, everyone, and welcome to today's presentation. I'm excited to have you here as we explore the topic of peptic ulcers. On this first slide, you'll see the title Peptic Ulcer, which refers to a break in the lining of the lower part of the esophagus, the stomach, or the upper part of the small intestine. We will also look at the different types of gastritis that occur, specifically gastritis A and gastritis B in this presentation. We'll cover what causes these conditions, their symptoms, and how they are diagnosed and treated. So, let's get started and learn more about this important health topic. Now, moving on to slide 2, let's focus on type B gastritis and how it appears under the Wharton starry stain. As you can see in the picture, the black dots indicate the presence of Helicobacter pylori. This bacterium is actually the leading cause of peptic ulcer disease, or PUD, which we discussed earlier. Helicobacter pylori are gram-negative coccobacilli, meaning they have a specific shape and cell wall structure, and importantly, they are non-sporing, so they don't form spores. One key point here is that eradication of Helicobacter pylori is possible with appropriate treatment, which can significantly reduce inflammation and prevent complications. The route of transmission for these bacteria is primarily the fecal-oral route, meaning they spread through contaminated food or water, or poor hygiene. Lastly, these bacteria are extracellular, which means they live outside the host cells, attaching to the stomach lining but not invading the cells themselves. Understanding these features helps us grasp how they cause gastritis and how we can target them effectively. Let's start with the mechanism of action behind H. pylori. When the bacteria produce urease, it breaks down urea into ammonia and carbon dioxide. The ammonia is alkaline, which then irritates the G cells and parietal cells in the stomach lining. This irritation leads to an increase in acid production, a condition known as hyperchlorhydria. The excess acid can then cause ulcers, and interestingly, duodenal ulcers tend to be more common than gastric ulcers. Now, moving on to the workup for diagnosing H. pylori infection. The screening test of choice is the breath urea test. It's non-invasive, simple, and also the best method to confirm whether the bacteria have been eradicated after treatment. In some cases, an invasive urease test, such as the CLO test, is used. During endoscopy, a small stomach tissue sample is taken and tested for urease activity. Lastly, biopsy with Wharton starry stain can be used to directly visualize the bacteria in gastric tissue. All of these tests help us accurately diagnose and manage H. pylori-related ulcers effectively. When it comes to diagnosing Helicobacter pylori, the most accurate method we have is the stool antigen test. It's reliable and non-invasive, making it a preferred choice in many cases. Now, let's talk about treatment options. The standard approach is usually a combination of antibiotics and acid suppression therapy. The most common regimen is the triple therapy, which typically lasts for about 2 weeks. This includes a proton pump inhibitor, such as pantoprazole, to reduce stomach acid and create a less hospitable environment for the bacteria. Along with that, we use clarithromycin and amoxicillin or clavulanic acid, which work together to eradicate the infection effectively. In some cases, if the bacteria are resistant or the initial therapy fails, we might opt for quadruple therapy. This involves bismuth, tetracycline, metronidazole, and again, pantoprazole. The addition of bismuth is significant because it helps protect the stomach lining and enhances the effectiveness of the treatment. It's also important to note that erythromycin is not used for H. pylori treatment, despite being an antibiotic, because it's not effective in this context. Lastly, bismuth has a unique role. It acts by reducing the contact time between stomach acid and the mucosa, which helps in healing and provides additional protection during treatment. So, understanding these treatment strategies and their mechanisms is key to effectively managing H. pylori infections and preventing complications down the line. Let's talk about type A gastritis. This condition is actually an autoimmune disorder, which means the body's immune system mistakenly attacks its own stomach lining. It's considered a premalignant condition, so it can increase the risk of developing stomach cancer over time. One of the key features is the presence of specific antibodies, like anti-intrinsic factor cell antibodies and antiparietal cell antibodies. These antibodies target cells in the stomach that produce important substances. Because of this attack, the stomach's ability to produce acid decreases, leading to achlorhydria, which is the absence of stomach acid. This reduction can cause gastric ulcers and also impair the production of intrinsic factor, a vital protein needed for vitamin B12 absorption. When intrinsic factor is deficient, it often results in B12 deficiency, which can cause pernicious anemia, a type of anemia characterized by large, immature red blood cells. Additionally, the lack of stomach acid causes hypergastrinemia, or elevated levels of gastrin hormone, as the body tries to stimulate more acid production. But since the acid production is compromised, this creates a feedback loop that perpetuates the condition. Overall, understanding these mechanisms helps us see how autoimmune gastritis not only damages the stomach lining, but also has broader implications for nutrient absorption and cancer risk. Let's take a closer look at the differences between gastric and duodenal ulcers, focusing on some key points. Starting with blood groups, we see that gastric ulcers are more often associated with blood group A, whereas duodenal ulcers tend to be more common in individuals with blood group O. When it comes to the site of the ulcers, gastric ulcers are typically located along the lesser curvature of the stomach, while duodenal ulcers are usually found in the first part of the duodenum. This difference in location is important for diagnosis and management. In terms of symptoms, both types can cause epigastric pain, but the pattern and associated features differ. Gastric ulcers often present with epigastric pain that may be worse with eating, sometimes leading to weight loss because eating can exacerbate the pain. Conversely, duodenal ulcers also cause epigastric pain, but are often associated with hunger pain, which tends to improve with eating, and they can lead to weight gain or overeating in some cases. Another key point is the timing of the pain. Postprandial pain, pain after eating, is common in gastric ulcers, whereas in duodenal ulcers, pain often occurs a few hours after meals and is relieved by eating. Recognizing these patterns helps in differentiating between the two. Overall, understanding these distinctions is crucial because they influence how we approach diagnosis and treatment, ensuring that patients receive the most effective care based on their specific ulcer type and presentation. Let's now discuss some of the common complications we might encounter. First, gastric ulcer. A gastric ulcer can be a significant source of bleeding, and notably, the bleeding often originates from the left gastric artery. When managing such a case, our primary goal is to stabilize the patient hemodynamically, which we achieve through IV fluids. Once the patient is stable, we typically proceed with an upper GI endoscopy, which allows us to visualize the ulcer directly and apply cautery to stop the bleeding. Moving on to perforation, this is a serious complication where the ulcer creates a hole in the stomach wall, allowing fluid to leak out into the peritoneal cavity. If the perforation occurs near the foramen of Winslow, the leaked fluid can enter the lesser sac, leading to peritonitis in that space. Finally, gastric outlet obstruction, or GOO, is another concern. When this occurs, the stomach becomes distended, and we often describe this as a teapot stomach because of the characteristic shape it takes on. All of these complications highlight how important early detection and management are in preventing more severe outcomes. They also underscore the interconnectedness of the anatomy and the clinical signs we observe, reinforcing the overall importance of a thorough approach in gastric pathology. Now let's look at duodenal ulcers, starting with perforation. Perforation is more common on the anterior wall of the duodenum, but it can also occur posteriorly, though less frequently. The most common complication associated with duodenal ulcers is peritonitis, which typically results from perforation. On an abdominal X-ray, one of the classic signs we look for is the mustache sign, which indicates gas under the diaphragm. This is a telltale sign of perforation. When it comes to bleeding, Posterior ulcers tend to bleed more frequently than interior ones because the source is often the gastroduodenal artery, which is located posteriorly. In terms of management, endoscopy plays a crucial role. During endoscopy, adrenaline can be injected at the base of the ulcer to control bleeding, and electrocautery can be used to coagulate the bleeding vessel. This approach helps stabilize the patient and addresses both the perforation and bleeding effectively. Understanding these key points helps us connect the clinical presentation with appropriate diagnosis and intervention, ultimately improving patient outcomes in duodenal ulcer complications.